make it a little goofy. Ooh, I hit the wrong one. Okay, so I know, like, that chapter, you forget, like, these two chapters, especially the documentation and the head to toe, this takes it way back, okay? So make sure, I mean, they're only like 2 or 3 pages apiece, okay? But don't forget to go and look back on the way I'm gonna test, like, on the documentation chapter is gonna be examples like this, like, what would you document under this section? And then, like, what would be, which one of these would be the correct way to document about the heart? And I'll give you multiple options, and sometimes it may be like, what's the bestest answer, okay? So, or goodest, what's the goodest, So go back, those chapters are very brief, and a lot of it should be a reminder, but just don't forget to kind of look under like all those different little sections that say, like functional, what are you gonna do under the functional assessment? What are you gonna do under, what would you document under respiratory? So please go back and take a look at it. I feel like this feels like it's a long time ago, but it's not, it's a part of that chapter. Should be a good reminder for your final. Okay, so obviously you need to know about informed consent. So you need to make sure you know all the guidelines that we need to follow. You also need to not only know these guidelines, the correct ones, but also like why do we need one? What is included in an informed consent? When is like someone incompetent? So make sure to review all over the informed consent. I made this one easy for y'all, but it was purposely to be a reminder. Okay, so I made that easy, but remember, there's that sheet that I attached that's about the National Patient Safety Goals. Go back and look under each section and find like what falls under those categories. A lot of them are pretty self-explanatory, but review back over the National Patient Safety Goals because that's a big deal when you go to the hospital as well, being familiar with those. So you will be tested over that. Y'all know I had to go here. Y'all know I had to ask it over and over the other day in class. What are some of the other things? So it's the rapid weak pulse, what? Hang on. Low blood pressure.
Higher heart rate.
High heart rate. Tachypnea.
Low pulse pressure.
What'd you say?
The low pulse pressure.
Yes. There was another big one.
Cold and clammy.
Cold and clammy, pallor, and urine, decreased urine output, concentrated urine, okay? Good job. Y'all review back over all that. You remember what the Aldrich score is? Don't answer that. Don't kill me.
I knew that one.
Okay, so what does it need to be above?
7. Or I
So
thought-
it says 7 to 8 on the sheet, okay, on y'all's. I did look at the bottom of that, so it says 7 to 8, and I wanted to remind y'all of that. So first off, what is the Aldrich? Okay, so what is it, yeah, certain criteria, and what are just a few of the things, like what are some of the big things it's assessing? O2 sat, activity, What do you say, level of consciousness, yes. Circulation, blood pressure coming up, that's a big thing, okay? So go back and look at that, those kind of categories. How often are we assessing them that first hour? Every, what? 15 minutes. And then we're gonna assess at that hour mark, is our patient able to be, so at a 5, where are they gonna go? ICU. Okay. Or they'll go to ICU. What's that? Do you know what that one is? You know what that thing, that stop button is? Okay. All right, y'all. So, I wanted to remind y'all about stop buying because I did not pull that up. I had said I was going to go back the other day and pull it up. I mentioned you needed to know it, but I didn't go back and pull that up. It's not on my PowerPoint. I don't do it sometimes. But there's some criteria that you need to look over, you know. And so, what age do you know? 50. Yeah, it's an older one. That's a good, safe answer. What about, it's not hypotension, it'd be what? Hypertension. What about who is male or female? Males are at higher risk. And so you just think about people that are larger, truncal waist, larger necks. So please make sure you go back and review over that stop buying piece of paper that I gave y'all. Because that's important, because this is stuff that we talk about when y'all go to the hospital as well. You do assess this in your patients for real as well. Starting tomorrow. Yay. Be what the patient reports. So remember, review of systems is what the patient says. The history one is going to be, of course, they are reporting it, but it falls under the history part, okay? So go back and look at your sections and know what needs to be documented in those sections. What else needs to go on there?
Is it time?
Yes. So location means where it's at. Then site is there any redness or swelling? So that's something we have to make sure we're documenting. That's a big thing that happens a lot in hospitals is they get infiltrated or infected. And so we do every 2 hours you need to make sure that you're assessing that, okay? And I'm going to do some more review about the hospitalized patient after we're done with Kahoot. Okay, so we don't normally on everybody go and do an eye examination, okay? So I want you to, in your chapter, I want you to look at the assessment chapter, because a lot of students don't realize the way this is worded. You know, when we went through everything, we just covered everything, you know. But in that chapter, it kind of brings to light where I keep telling you, like, you assess something a little bit, and then you go down the rabbit hole. That's pretty much how that chapter is. You'll see sections that'll say, if, you know, then you will do. So then you would go into doing more of the eye exam and do all the different testing, okay? So pay attention to in that chapter. There's little statements that'll say that'll take you down to some of those other assessments if something else is positive. That makes
So like the head to toe we did today, we won't do that eye thing on everybody?
Actually, you're supposed to. You are supposed to do the pearl one. You are supposed to check pupils.
Is
Yes.
this talking about like the Snellen or whatever?
Yeah, this is eye examination, like, yes. So this would be just pupils. You just do like pupils. And that's more of a neuro, so we do a neurological check. And so that's a big thing in the hospital, is are they awake and alert and oriented, their pupils and
So
their
you
grip
don't consider
strength and their
per
fee
look
strength.
an eye exam?
No,
Okay,
not a full
I
eye,
gotcha.
no.
I gotcha.
And so that is just a basic, what we call the neuro assessment on all of our patients, but does it, no, they don't, but you're supposed to. I probably forgot about this one, cause it was on the module, but I didn't get to it, so I wanted to remind y'all. And I kinda just threw this in here to make y'all think about it, you may not know it, it's okay.
Vaguely remember this.
Okay, so, this has to do with, of course, administering pain medications and a patient's response. And so in the surgery chapter, we do talk about, giving pain medications, assessing and monitoring them, reassessing them like 30 minutes in an hour, depending on PO or IV. But a big thing that we have is the POS, and you'll see this at the hospital, especially Wilson will utilize it. Make sure you look on my module under Canvas, because it's 4-point scale is what it is. And that scale is for us to walk in the room, and we didn't used to have this, this protects us. So if we walk in and the patient is awake, alert, and oriented and talking to us, that's a 1, and that means, okay, they're good to get their pain medication, if it's time. If you walk in the room, they're a little lethargic, but they wake up good and they arouse and can talk to you and make sense, we can still consider giving them. A 3 and 4, we are not. That means they're waking up, or maybe they're not hardly waking up on a number 3. You maybe can get them aroused, they're very lethargic, they fall right back to sleep. Am I gonna give them some Dilaudid? No. And that's like, it kind of protects us. We may consider doing something different, a different type of pain medication. Number 4 means you can't hardly get them aroused, okay? And if you can't get them aroused, you're definitely not gonna give them an opioid, and you're probably gonna end up giving them some Narcan, okay, and calling a rapid response. So take a look at that chart for me, okay, because you're gonna see this. And it's something you may possibly see when you're at the hospital this week. Okay, well, I knew y'all would get that, but the reason why I threw this in there, well, I hope y'all did. The reason why I threw this in there was to remind you though, what are some other things that we need to consider about their diet post-operatively?
6 small meals.
6 small meals,
Don't drink.
fibers, don't drink at the same time,
Low calories.
yes, afterwards, high protein, low sugar, we don't get a lot of sugary. Okay, so make sure you review over the diet instructions that they would have. I just realized, do y'all know what SCDs are? Okay, I went, oh, I didn't realize I did that. Okay, well then good. TED is another one, that might would be, an option as well. So with the bariatric surgery and also with other post-op stuff, there are certain complications that are common that you'll see. But with the bariatric, DVTs, so what are some other things that might be an option for them to prevent it? Walking, early ambulation, yes. Anything else? Yes, given the heparin, the low heparin injection. So Lovenox is what we call it. So they may do that. There are some more complications that occur commonly after bariatric surgery, okay? A lot of them may have to do with some forms of obstructions, valves not closing, what signs and symptoms might they exhibit. Remember we talked about the one where if there's like a leak at the anastomosis where it's sewed back, and y'all should know like peritonitis, the signs and symptoms that patient might get if they're leaking in their belly, so remember those. review for final. Good job. So what's the other one? And that happens in what location most commonly? Abdomen, and what happens? Yes, insides come out, yes. And what are we gonna do?
Sterile gauze.
Sterile saline soap gauze, and we're gonna have them in a low Fowler position, and we're gonna hold it over. Yes! Help! You're probably gonna holler it in the room if you see it, but first time. Okay, so remember the mental health chapter. There are examples of different disorders at the back that we went over. You know, like I said, you're only gonna need, I may choose some of them that have the most common standout signs and symptoms on them. You know, it was things like anxiety, depression, post-traumatic, disorder, postpartum depression. It's just gonna be more about the signs and symptoms, because we're just, like, if you were sitting there talking to them, what would stand out to you that they were experiencing that? So that's the main thing that I want you to know. Also, I don't think I have another one on here, but don't forget about, there's risk factors for depression and anxiety you need to be familiar with. Watch it be the next question after I said that anyway. Okay, y'all, there's a little chart in the chapter, and it goes over the different things if you were assessing the eyes, what they might experience if they were intoxicated. So go back and make sure, looks like we need a little review on that, take a look at that and see what would be some positive findings for intoxication. So what is this one?
Remote is like callback from a long time ago, like
Yes.
when they were in high school.
And so what is this one?
This one is recent.
And
Well,
then,
recall.
I actually didn't put it very clearly, because it could be that if I say something and then I get you to say it right back to me, it's what?
Recall.
Immediate recall, and then the other one 10 minutes later,
It's remote.
okay, is recent,
yeah.
recent. So don't get your R's mixed up. So recent means that I said it a while ago, recently, and you repeated it. Remote, just remember it's very remote back in the day or something. Don't get your R's mixed up. Oh, there is one right sign. There we go. It was easier for me to do it like that and pick right answers. It's easier to get.
What?
Hold up.
Oh no, it's the wrong one. Which one should it be? It should be.
Desert.
Yes, I clicked on the wrong one. That was my fault. Yeah, I told y'all I did this fast, but no, it is, that's correct, because it does work. It does run it down. Sorry about that. I need to edit that before I post it and everybody be like, so make sure you know your signs and symptoms. Then they'll miss it on the test and it'll be knocked off. I'm gonna fix that. Everybody heard that right answer. No, I'm nervous. Okay, so remember in the chapter, there's all these other ones that are options or something that you might look at, so know what category they fall under. whenever we're checking for cognition and to see whether or not they're thinking rationally. Make sure you go back and assess that, or review that. It talks about calculation ability, there was a way that you would assess that. Copying, so I would basically give you an example, just like I did this, or vice versa, say, how do I assess this, and you'll choose from it. So go back and review all those ways to assess the cognition. Oh, we're done. Okay, so let's review real quick about a little bit more on the hospitalized patient, that chapter real quick, okay? So what all do I need to assess for a Foley catheter? Not everybody at once. Output, what about the output? How much? What else? The color. There's like in the area? Yes, okay. Yeah, the insertion side.
Is there any sediment inside of the?
Any sediments? Yes.
Any kinking in the tube?
Color. Any kinking in the tubes? Is it clamp? What else? Anything else you can think of?
Like distension,
Any?
or is that not really part of it?
No, it can be bladder, because just because they have a catheter, it could be kinked, it could be stopped up. And we do have patients that we get a lot of Murphy drips on our floor because males are bleeding and they clog up. So they'll get abdominal distension. So that would be something, you do need to know the French, and also for documentation purposes, you need to know the size of the balloon. Whenever you're at the hospital, and you'll see that on your little Y of your catheter. People will say they don't know how to find that. If you can't find the chart, you can literally walk over and look on their leg where it's attached, and you'll know what French, okay? We already went over the IV. What about if someone has a cast?
Their toes.
Their toes. What kind of check is this that we're... Perfusion. It's called the what kind of check? Assessment. Yeah, neurovascular. Those 6 P's, remember? So remember ortho and cast is an ortho. Make sure that you're going to do those checks. So what else? So we got color.
If they can move.
If they can move. Capillary refill. Sensation. Temperature. Good job. And pain. Look at y'all. What about NG tubes?
Make sure that's the skin around the
Look at the skin.
Make sure it's in the right place.
How are we going to know it's in the right place?
X-ray.
X-ray.
And,
Or you can aspirate. Okay. What else?
make sure the tape is still in and breaking their skin down.
Yeah, because that can break the skin down. Yes. What
Make
else?
sure the for the tubing, that it's going down to the gravity can fill the.
Okay. And if it's to gravity, but also we connect it to suction. So you want to follow it back up and know, what order, is it continuous? Is it intermittent? What are we going to look at on our canister? The amount. We're going to document that. We're going to mark it whenever we come in. We want to know how much they have when we came in so that we can watch it and see if any more comes out while we're there. If they've been having a bunch and all of a sudden they don't have any, I'm concerned. Something's clogged up or kinked off, okay? Or not in the right place. Of course, don't forget little things like if it's an NG tube, you need to do your abdominal assessment. So don't forget that with any of these, okay? Like if it's the trach and it's respiratory, we still do the full respiratory assessment as well. Let's talk about trach. What do we assess? The skin around it. Secretions. The ties. Lung respiratory assessment. If they have any oxygenation on it, what it is, what it's set to on the wall. What about nasal cannula? Patient's got nasal cannula. What are my assessments? Their skin. Pulse ox.
How much oxygen they're supposed to
How much oxygen? Make sure it's connected to the wall. I know that sounds silly, but you'll go in there and they're desatin or cyanotic, and all it is then get replugged back up to the wall. What if my patient has a colostomy?
Check the bag, make sure.
Check the bag. What am I checking the bag for?
How full the stool.
Stool, how full it is, so it needs to be empty. Assess the stool, and it's going to depend on where it's at as to the expected type of stool that's coming out. Assess the skin. How does the stoma need to look?
Beefy.
Red, beefy, moist, okay? Protruding, yes.
Yes.
That's not normal, but sometimes I will say they will leave them like that if it's you know, sometimes they're a little risky to go back in and do the surgery. If it's functioning fine, then they'll leave it sometimes, so you might get a shock of your life. What about an incision? Say they've had an abdominal surgery and they have an incision. What am I gonna look at? Discharge or drainage. Approximation, meaning it's together, the edges are together. You need to know whether or not, like, it's sutured or if there's staples. What else?
Make sure they have their pillow or
The splinting, teach them how to splint. What else? What if they have a dressing on it?
make sure
Well, the first dressing, yes, in that surgery chapter, we talked about that. The surgeon changes the first dressing. What happens if it begins to have blood on it? All over that first dressing, what are we going to do? We are going to call the doctor, but we're going to reinforce. And we're going to call the doctor, okay? We're not going to rip it off. What else? What if I have a JP drain?
I'm gonna check the drainage amount, color.
Okay, the color, the amount.
We have to squeeze it if it's out.
Yeah, squeeze the bulb, either the JP this way, the hemovac this way, or squeeze the Davol, which we'll show you all those in the real world because we have those a lot on our floor. Let me think, what else? Sorry, I know this is a lot, but y'all need to know some reminders of this stuff because y'all may see any of this stuff tomorrow. Aren't y'all excited? I get so excited about this time. Is there another thing in that chapter that let's talk about, real quickly, like, okay, we went over informed consent, in the pre-op chapter. Make sure you go back and look at, there was things that we ask about and we assess on our patients pre-operatively. Like example, for instance, nutrition. What are some things that might stand out about nutrition you'd want to know?
If they were eating protein.
Yes, if they're eating good protein. What about our little old people? They might be what? Dehydrated, fluid status. We worry about hydration because we also worry about electrolytes, okay? So make sure you think about that. Medications, you know, whether or not they're taking any medicines, because there might be sometimes we hold them, but there may be a time that they want them to take them. Like their blood pressure may be really high. Are they going to get to have surgery? No. So they may want them to take them. What about our diabetic? Yeah, we got to monitor the sugar. Because more than likely they're NPO. Why is a patient NPO before surgery? What is the primary reason? So they don't aspirate, okay? And so they're NPO, so what's going to probably happen to sugar? It's going to lower. So are we probably going to treat it like we normally would? No, not normally. I'm going to tell you there may be cases though where you possibly would, because when the body's under stress, the glucose does go up sometimes on its own. That's just a natural response, okay? Make sure the allergies, we talked about the different diagnostic tests, going through their checklists, EKGs, things like that if needed, for their assessments. We're going to teach them in the pre-op part about what to expect in the discharge, okay? So let me think about what are some things with in the post-op. So what is the main thing we got to make sure we're assessing? Breathing, okay? So when they come out of surgery, what are the things we're assessing? Besides breathing? Their airway and vital signs. Because hemodynamics is very important post-operatively. Because what is one of the common complications that occurs post-operatively? Hemorrhage. And that goes into those signs and symptoms of hypovolemic shock. And the other one is infection. But when does infection tend to occur? A few days later. So that might not be initially. So make sure you know some of the common complications that you would see and what we would need to make sure that we're assessing on them, okay? Can y'all think of anything else that we need to throw out there? I'm trying to think of if there's anything that stands out.
Obesity.
Oh yeah, so on the obesity will be mainly about who would qualify for bariatric surgery. We went over that. You can't just decide you're just gonna go do it. There's things that they need to go through and try to do prior to bariatric surgery. Big things that I'm focused on is the post-operative. What are we gonna tell them to need? And y'all talked about the diet, things for them to expect, how much that they would be able to drink post-operatively. There was complications that were common with them. make sure you go back and take a look at that. I think I already mentioned that. You do not have to know all the different surgeries, like the different types. Because the main thing is for you to understand, we're taking that stomach and we're shrinking it down, and that doesn't vary. Now, there are some of them, because they are cutting out a lot of it, they're not absorbing like they should, so they may need to take some supplements. So make sure you're familiar with that, what supplements they might would need, because they're not getting as much nutrients as they normally would.
Would you want to know wound healing, like the indentions?
Yeah, so with obesity, you do need to know, like, there's common complications in that chapter. With obesity, one of them is wound healing, impaired skin, obstructive sleep apnea. They may need a CPAP machine. That was sections in there as well. You will need to know that. Some of that kind of goes with the post-op stuff as well. Anything else?
Shouldn't obstructive sleep apnea improve in post-surgical bariatric patients over time?
Over time, yes.
Because
Yes,
it's like
most of the time, it is the weight, and so it should, yes. Yes. Should improve. How about any other questions? Okay, well, thank y'all for waiting and stuff. I appreciate it. It's duly noted. I'm debating on what